My name is Mariana. I am the CEO and co-founder of the After Cancer. And we're here today with Katrina and Rachel to talk about sexual health after cancer. So, before we get started, I am going to present just a little bit of background on why we do these sessions. The goal of these sessions that we do at the After Cancer once a month is really to raise awareness about cancer survivorship and all of the englobing topics that cancer survivorship has. And today we're digging into sexual health. Um, we have here this short video just talks about what we do at the After Cancer. So we are a digital platform for cancer survivorship. So we offer an app for patients to use that delivers real patient outcomes. We're really seeing amazing results for patients at home, and we do this with a really new approach. So we have an app that patients follow, and it includes a daily plan and content and group sessions and also community. And we're really excited to see how the After Cancer is being used in different hospitals and health systems and nonprofits to really enable their teams and providing comprehensive programming for survivorship care. Start the conversation, and I think the best place is to get an introduction from our two speakers. Rachel, could you just quickly introduce yourself and tell us what you do?
Yeah. My name is Rachel Murray. I am a women's health nurse practitioner, and I have a private practice based out of Waxhaw, North Carolina. I see patients telemedicine and in person in North Carolina, and then also virtual only to Virginia. And my practice is focused on women in menopause, perimenopause, and that's inclusive of women who cannot do hormones. We do non-hormonal treatments and discuss lifestyle interventions that we can do for women who may not be able to do hormones. And then also, I do sexual medicine as well. So I'm a fellow of the International Society for the Study of Women's Sexual Health, which is one of the world's leading organizations that really focuses on issues around sexual medicine. And my focus is on addressing all of those issues: painful sex, decreased libido, decreased arousal. All of these things also, as we're going to discuss, can have an impact when one is going through cancer and cancer treatments. So yeah, that's me.
Thank you. And Dr. Katrina Heath, over to you.
Hello, everyone. I'm really excited to be here. I am Dr. Katrina Heath, and I am so thrilled to have the conversation today with you all about pelvic health. I am a pelvic floor therapist, and I have had the wonderful opportunity to work in pelvic floor for the past 19 years. I've been a physical therapist for 23 years, and I've worked for different companies, some that you may have heard of: Atrium Health, Wake Forest Baptist Medical Center, Princeton Medical Center, which is a division of Penn Medicine. So I've been able to work with women, men, and children in the space of pelvic floor dysfunction. And so for some of you who may or may not understand what pelvic floor dysfunction is, it is any muscle imbalances that happen between the pubic bone and your tailbone. So if there is dysfunction, as in urinary.
August 26, 1962. And I'm calling to update on my medical
Hey
record.
everyone, if I can just ask you to mute your microphone, please, just to make sure that we can hear the speaker. Really appreciate that.
Sorry, I don't know what happened, but or where I was, but I will say that I enjoy treating pelvic floor dysfunction for women, men, and children. And that's issues of painful intercourse. It may be pain with sitting, pain with walking, any type of discomfort in the pelvic area, as well as urinary incontinence, urinary urgency, frequency, constipation, bowel issues. Maybe you have bowel incontinence after colorectal surgeries, chemo, radiation, and things like that. So I love treating all of it, and I would love to hear more questions once the floor opens as to what you all may want to ask me about.
Thank you so much for your introductions, Rachel and Katrina. So, we wanted to talk about sexual health because we know that this is a bit of a taboo. Like, your oncologist is not going to talk to you about your sexual health and pelvic health during visits. And we see that oftentimes patients go home and they suffer in silence. They don't know what to do. And so when we thought about approaching sexual health and survivorship, we wanted to have this duo of pelvic floor rehab, which is a really important aspect, and then also have Rachel as a nurse practitioner, like sharing her information and how she treats patients. And I think we can start with just really talking about and creating a shared understanding of what are the most common sexual health symptoms that cancer survivors experience. Katrina, over to you. Tell us about what are the most common symptoms that you see patients experiencing in your practice.
I think the first thing that most people are experiencing is the loss of sexual desire. Around the time of diagnosis, a lot of times I think the focus is more so on let's make sure we take care of the disease itself, and we don't really talk much about what the after effect is going to be. And so I think if we're able to speak to that more on the front end, just letting people know that this may be an issue afterwards, here's a resource for you. So we see a lot of people who don't have very strong sexual desires, even, lack of body image. They may feel like they're not that same person anymore. And so really trying to help them overcome the mindset that even though this may not be what you're used to, we're going to thrive through this moment. And we have to shift our mindset and change. And so I think that's the first thing. But we see a lot of people who have issues with pain, sexual pain, erectile dysfunction, just pain and discomfort with sitting, sometimes standing, sometimes walking. Of course, sexual dyspareunia, which we call painful sex, decreased orgasm. See a lot of that. And then a lot of patients who have issues with the vaginal dryness or decreased elasticity. So the depth of insertion may be a little bit different afterwards, and we try to help them to manage that better. I think those are probably some of the main things. And of course, there's a lot of fatigue, tiredness of clients, and then there's a lot of guilt around that. So again, I think the mental health piece is really important, and I think is really connected to physical health.
Yeah, I loved how you started talking about the mental health aspect of it, lack of sexual desire, body image, guilt. We see a lot of relationships being affected and impacted by cancer. And that's something that definitely needs to be approached by providers like yourselves. I think we can dig into that in a bit. Rachel, are there any common symptoms that Katrina didn't share that you see in your practice? Oh, you're on mute and muted. Perfect.
And this is why we align so well with pelvic floor physical therapists, because I can just echo everything Katrina was saying. But my answer is really the same. It's the number one thing that I believe that we need to look at first is body image and mindset, right? Because that can then lead to a cascade of issues. And I think what gets lost in translation so much of the time is that a cancer diagnosis has a massive impact on a woman's experience in her own body, and thereby her experience with intimacy and her experience then with her partner, which can just trigger things for years to come. And then, of course, we get into from there the issues with libido, the issues with painful sex, the issues with being able to climax, and we want to address accordingly.
And for the mental health aspect, so we're talking about that you guys are talking about, what are your approaches in supporting patients that are experiencing that? Rachel, can you share what you usually do in your visits and how you help them, one, understand the issue, but then two, also treat it or manage it in a certain way?
I think the most important thing is to meet a patient where they are. It is so, so valuable to have that gentle approach, to let women walk in, to let them tell their stories. And people are going to be in a different place. Some women may not even know what happened to them when they got their cancer diagnosis 10 years ago because no one's ever spoken to them about it. Some women may be angry. Some women may be hesitant to talk about it. And that's based on cultural norms or the fact that they haven't discussed it with anyone. So approaching it with a curiosity, approaching it with a gentleness, and being willing to meet patients and give back to them what they're wanting back, not needing to give them all the information at one time, but really kind of gauging, is this a patient who wants to do all of the things all at once? She's so frustrated. She's been to so many people and she just wants answers. Or is this a patient where we really need to take a step back and take it one step at a time, using a multidisciplinary approach, and make an intervention plan from there?
I love how you said meeting patients where they are, because I think that's something that we repeat every day at the After Cancer with the work that we do. And I see my co-founder, Dr. Bailey Dorton, who is a physician, and a lot of times she does like a survivorship plan with an integrative oncology approach to patients. And she always says, I have my opinion on what that patient should be doing, but I need to meet the patient where they are to make sure that then they'll follow through the proposal. And so if they say it's nutrition or sexual health or fatigue, like then we'll make a plan according to their needs, because then she's sure that they'll kind of like be committed to working on that specific symptom. So I really love how you're position your work in that way. Katrina, when you see patients going through this mindset, body image issues, lack of desire, low libido, etc., like what's your approach in helping these patients?
So the first thing I do, very similar to what Rachel was just saying, you have to take a step back and let them guide, let them tell you where they want to go. I think hearing their story, listening to them, like she said, a lot of times they've never had a chance to express or tell their story. So a lot of people are sitting and crying and really expressing themselves in ways that they have not, because no one has taken the time to listen. Some of them haven't even talked to their partners about it in depth. They just know the result. The result is I'm not able to perform as I was at one particular time, but here's the reason why, right? We may talk about mindfulness, having to shift their mindset in the form of positive affirmations, things that they have to do for themselves on a daily basis. We talk about mindfulness a lot. I do a lot of breathing with my clients because that helps to activate their vagus nerve, which is a calming, um, effect that we have on our own bodies, and it's innate. It's something that we were born with, but we don't always activate it, and especially at times of stress we tend to hold our breath, or we take very shallow breaths. So as a therapist, the neuromuscular re-education around that mindset, as well as your body being able to follow through with what you're doing. Breathing really helps with that. So we do a lot of deep breathing, diaphragmatic breathing, different types of breath patterns. I do a lot of breath work in my sessions, because not only does it help with calming, but it also helps with the pelvic floor. So your pelvic floor and your diaphragm actually work together. When one descends, right, when you take a breath in, you inhale, your diaphragm descends and your pelvic floor also descends. So you have to think about, when you're trying to receive your partner, you need to do some deep breathing in order to be able to help relax the area to improve your ability to have insertion. So there's a lot of work that goes around mindset shifting, positive affirmations. What are you telling yourself? Being able to release, your story, and to be understood. I think that's another aspect. And also to talk to someone who has seen people overcome, that's a positive thing for a lot of people. And again, they probably have never shared with others, or if they've tried, sometimes I think in doctors' offices, we may not necessarily share everything because they may not have the time to listen, to a 30-minute story or however long it is. So I'm very appreciative to be in a space now where I can listen and I can take the longer time of 90 minutes, 60 minutes, 75 minutes with a patient.
Thank you for sharing that. So we touched on kind of like the main symptoms that show within like the mental health, and a couple of strategies on how to support women with that. I would love to get your views on the main symptoms from a physical health aspect and what patients can do. Rachel, you mentioned, or Katrina, you mentioned pain, vaginal dryness, issues with elasticity. What is your approach to understanding the patient's main physical side effects, and then what is the plan and what are the next steps?
The next steps can you ask that question one more time?
Yeah, sure. So when a patient comes to you and they're experiencing physical side effects, and the different symptoms will have different approaches, but let's talk, for example, about pain, or intercourse pain. How do you support patients in that aspect?
Okay. So first we start with breathing, again, trying to do more relaxation techniques. So I'll do a lot of stretching of the muscles that's actually attached to the pelvis and pelvic floor. So thinking about their inner thigh muscles, their glutes, their abdominal wall muscles, thinking about, their external rotators of their hips, because they get really, really tight. Again, the diaphragm and all of those muscles that's attached to the pelvis need to learn how to relax. So we start with that. And then I will move into spaces like we use specific tools in order to sometimes expand the vaginal wall. And a lot of people may or may not have heard of vaginal dilators or vaginal wands. I have an example here. I don't know if you all can kind of see that, but this is a smaller one. They graduate in different sizes. So I will show a patient how to use those at home when appropriate. Um, those are probably the biggest things when it comes to pain. If they have pain with sitting or things of that nature, we will have to give them specific types of cushions or towels to support in that area when they're sitting for prolonged visits, even if they're going through treatment. Or if they're sitting in for long car rides and things like that. So we'll have to accommodate them for that. But we also will use lubrications for the vaginal dryness. So things that are water-based, silicone-based. Sometimes we'll use those specific things I don't know if you want me to get into specific ones that I recommend right now, or
Yeah, I think we can maybe share that on a follow-up email after the session. I'm sure I already saw a couple of questions on the chat that folks are asking for resources, and so that's something that we should definitely share. Rachel, let me ask you a question. Thank you, Katrina, for talking us through pain. Vaginal dryness, that's something that we hear so much from our patients. Could you explain us the causes of vaginal dryness in cancer survivors, and like what would be the plan to be able to manage it?
That is such a pillar of what I do. And where I know this is coming up the pike, but where Katrina and I, for example, or any pelvic floor physical therapist would work very closely together. But the vaginal dryness is going to come from a couple of different areas. And when we think about sexual medicine, ISWISH, International Society for the Study of Women's Sexual Health, who kind of puts out various guidelines and different ways that we can approach sexual medicines, has come up with this regions-based approach. So when we look at women, we want to think about region 1, region 2, region 3, region 4, region 5, region 5 being the brain, region 1 being my very favorite part of our body, the vestibule and the clitoris, and the vagina. That's what it encompasses. Region 2 is more of Katrina's work, which is the pelvic floor. And the reason I mention these regions is because the source of the pain could be coming from various regions or one of those regions. The most common one, if a woman is going through cancer treatments, is going to be hormonal shifts, right? From chemotherapy or radiation, that's essentially going to, or tamoxifen treatment. These things are essentially going to drive estrogen levels to zero or very, very low. Estrogen is essential in the vaginal tissue and in the vestibule and at the clitoris. So then women are going to experience pain. They may not be able to climax as well. But if you're looking at the etiology of where these issues come from, we go back to anxiety. If a patient is anxious, or if she's all of a sudden out of touch with her body, that's going to impact her experience. That's not to say that it's all in her head. I cannot stand that phrase. I'm sure Katrina would agree with me, but it's such a problem, right? Because it is a very real thing for a woman's neuroplastic pathways, like, right, her response to her environment around her is going to shift and change and might be very much in fight or flight. And if it's in fight or flight, she can't experience the vaginal lubrication that she used to experience, thereby leading to pain. So we need to think about all of those aspects. The number one treatment we're going to use is vaginal estrogen, and women can often become nervous about that because of the word estrogen in response to particularly breast cancer, right? The vaginal formulations, generally speaking, are very commonly used. Oncologists most of the time are okay with it. And the reason is because we've done a number of studies on this, and it does not increase systemic hormone levels above that of a typical postmenopausal woman. So we generally think it is fine. There is some nuance to that, and informed consent is extremely important. And so we have to explain to patients the risk is not zero, but it's very, very low. There's also dihydroepiandrosterone. This is a precursor androgen hormone that gets converted to estrogen and testosterone once applied and sent to the peripheral system. It's thought to be a safer option. And then there's a few. So there's also hyaluronic acid, which is non-hormonal. Many patients feel safe with that. And there are some smaller studies that have compared the efficacy of that to vaginal estrogen. And it shows that both can be equally effective. And then also things like coconut oil can even be effective. And there are some smaller studies on that as well that can help with what Katrina was talking about, that elasticity, in a similar manner. It's not going to be as good, but these are still options if patients feel safer with that option.
Mm-hmm. Thank you. Katrina, I would love to hear about what type of cancer patients, like what diagnosis do you see in your office? Because I think oftentimes we think sexual health is going to be maybe a GYN cancer or breast cancer, but I know that pelvic health therapy goes like much more beyond that. So could you maybe share the types of cancers that you see and the reasons why you see them?
So it can be endometrial cancer, it may be uterine, it may be cervical, it may be breast, it may be colorectal, it may be prostate cancers. Those are probably the more common ones that I see. And the reason that I'm seeing them usually for prostate cancer, it is because they have had a prostatectomy. Um, and they no longer have urinary control. They may also have pain. They may have erectile dysfunction. So those are some reasons as to why they come. Then you would think with the endometrial or uterine, usually they have had hysterectomies or they've also had oophorectomy, some, and then some may have the, chemotherapy, radiation, and the tissues in the vaginal wall have um, become very fibrotic or have scarred. Um, the vaginal length is no longer there as much. I'm not going to say it's completely gone, but it may have depleted a little during their therapies. Um, there may have been also soreness within the mucosa. So some people get a lot of sores in the mouth as well as in the vagina or rectum as a result of having received treatment. And so we'll get, people in with pain or discomfort in the area. Those are some of the more common ones that I've seen.
Thank you.
And I was going to say also with breast cancer, you will get people because of the lack of range of motion that people may have within their latissimus or within their shoulders, as well as they may have had a hysterectomy or oophorectomy. And so we'll get them in as well. So they'll have more vaginal pain. Mm-hmm.
Got it. Rachel, do you see the same type of patients or anything that Katrina did not mention?
Yeah. Most of what I'm doing from a pain standpoint is going to be related to those tighter pelvic floor muscles. And so it's going to be, from my perspective, giving having the thorough discussion about the risk of vaginal estrogen versus hyaluronic acid versus DHEA, really getting clear with the patient on what she is most comfortable with, and also explaining what is most likely to work, and then having her work in conjunction with someone like Katrina, where Katrina and I can talk consistently also about progress. But the idea would be that if we're working on that tissue and helping to moisturize the tissue, we're helping to build collagen in that tissue, we're helping to mature the cells in that tissue and make it all more elastic. And then Katrina is able to work on that muscular shift, that it can completely change the game in terms of a patient's experience.
Thank you. And I'm thinking about the folks that we have in this call, and I think a lot of them are nurses in cancer centers and hospitals. Rachel, from your experience, like what are a couple of resources that these nurses can have in hand to help their patients if they don't have a referral within their hospital? You're on mute.
Thank you. There's a couple great ones. There's an app called the Rosie app. It's ROSY, that puts out evidence-based articles. It's founded by a physician. The articles are written by clinicians, nurse practitioners, pelvic floor PTs, sex therapists, psychologists, psychiatrists. But these are all different topics around sexual medicine: low libido, pain, decreased arousal. There's erotica on there because we know that exposure to erotic cues can be very powerful. That does not mean that a patient is going to get on there and watch porn if she doesn't want to, but it's just to say that it's a very comprehensive app, and it's an affordable app that patients can use when they don't have access. I believe that a huge piece of sexual medicine issues is related to the fact that we don't speak about it with our friends, with our family, in doctors' offices. any of the places. And so by giving patients that education that they can simply access on their phone is an extraordinarily powerful tool. Lori Brotto is a researcher who has done quite a bit of research on meditation and mindfulness and sexuality. She has a book called Better Sex Through Mindfulness, and I refer patients often to her website because on her website, she has actual guided body scans, and a couple of them are specific to low libido. There might even be one for pain, but it's reframing the thoughts and the mind around sex to try to help patients work through that. And the last one is a book that's written for patients, but also helpful for clinicians called When Sex Hurts. That is written by leaders in the field, Dr. Jill Kraft, Dr. Irwin Goldstein, Dr. Andrew Goldstein, and Dr. Pukal. And this is a multidisciplinary approach to addressing pain in a way that everyone can understand. You don't have to be clinical to understand, so that patients can then take that information to their clinician and say, hey, let's do A, B, and C.
Thank you. And a follow-up question on this. So I am pretty sure that some of the nurses that we have here and that deal with cancer survivors, they didn't even have any training specifically on sexual health. And I know that you both started this conversation talking about mental health and having a conversation, creating this safe space. Do you have any tips that can help these clinicians like have these safe conversations?
Katrina, do you want to go first? I just don't want to take over. If you want to go first, and then I'll follow.
No, you can go ahead. If you have something specifically, I was just gonna say some different resources that may be helpful in having the conversation is to have them read. And this is not a specific app, but it is it's like a pamphlet or guidelines, I would say, by mdanderson.org. That's the website, but it's on sexuality and cancer. And so it's probably about 40-page manual, and it really speaks to a lot of things that the patient may be going through. It explains it very in a lot of detail. And so that's a resource that can be used as well.
In terms of approach, I think two things. One is the gentle approach that Katrina and I mentioned, and letting patients tell their stories, and also being straightforward. So we're actually, there's a paper that I started on when I was still at Atrium, where Katrina used to also be, where we were looking at approach nurses, social workers, physician, nurse practitioner, our approaches, our own personal perspective on asking patients about these issues. And I think there's a lot of fear around it is where that comes from. And so I would say is just being straightforward, right? It's just asking the question, do you have any concerns around sexual medicine or sexual health that you want to discuss today? These can be common issues that women face. It's not ideal. You're not going to capture every single patient because that might throw some people off guard, but we start these things small and they expand over time as we can get people more and more comfortable with discussing it. And if we're too scared to even bring it up, it's never going to change. In the larger medical community, it's never going to change. So it's those little things that you all can do where we write papers and we look into these things. We come up with more organized ways of addressing it, and we figure out how to meet patients where they are. All of those little steps are ultimately going to move the ringer a little bit, so that this becomes more common speak.
Thank you. Katrina, any last thoughts on this?
Yeah, I also think that what she said is absolutely true. I think in my line of work, usually when people get to a pelvic floor therapist, that's usually their last resort. Like, it's almost like the physicians don't automatically tell them, right, this is who you need to see. They may say something like, well, this may help you. I don't know if it will, but try it. And I think we should be more proactive on the front end to say, if this is a problem for you, which it may be, right? Here is who you should go see, or here's a resource, or you need to see a pelvic floor therapist. You may likely have problems with erectile dysfunction, or you may have problems with vaginal dryness after having your hysterectomy or oophorectomy. You may have these issues. And so if you do, here is the resource, and tell them on the front end and having those conversations. I think also with pelvic floor therapists, we're asking the question, do you have pain with sex? Like, that is in their intake form. And so it opens the door very, even though people may be a little like, woo, I don't know if I want to say that. I think it gives them opportunity to be able to say it, right? And they may have never been asked that question before. So opening the door in the very beginning, I think is going to be helpful down the road. So they'll know, like, if I'm dealing with this now, if I don't deal with it, it's going to only perpetuate more problems down the road, potentially.
I just want to add to that. I'm so glad Katrina said that. And I'm not surprised. And it also makes me really sad, because truly, if I only give a patient vaginal estrogen, she is not going to have the same results. And I see this over and over again than that she would if she saw a pelvic floor PT. So these things 99% of the time need to be combined. The other thing, just to echo off of that, I get emotional about this. But we are diagnosing people with cancer, and we are not giving them the resources to live a good quality of life. And we are seeing patients years, decades later, with just, having felt guilt, having felt shame, having felt pain and sadness, struggling with their quality of life, having divorces, all of these things. And so as nurses or social workers, you do not have to be a physician to make change in this field and change that discussion. And Katrina is correct. We need to have this discussion as soon as we are giving that cancer diagnosis. This is not a form that we shove in front of a patient and we say, you have breast cancer, and then, okay, go get chemotherapy. This is so much bigger than that. And there is no system for it. I can't tell you how many patients I've seen, and Katrina just said it herself, who have gone years and suffering and pain before they actually find us, and they find us by happenstance. So, one of my missions that I will work toward, and I'm happy to work toward it with anybody else, is to change the way we're discussing this when we give these diagnoses, so that we can really change lives in an impactful way very early on.
I don't know if you saw all of the emojis, and you're getting so much support on the chat, because I think it's with that love of passion and compassion that we really need to take care of these of patients. That's why we started the After Cancer, is because there's no resources. We want to make sure that we find a safe space. And I think safe is very important, because not having resources means patients go online and on Google and ChatGPT and Facebook groups, and there's so many things out there, but it's really like, how can we guide them in this life after cancer? And I think there's something that you mentioned, Rachel, and we've seen this within our patients at the After Cancer, which is how relationships and marriages and everything is impacted. I would love to hear from both of you any tips on how we can support patient in having these conversations back home, because that's also really hard. It's hard to have this conversation in the first place. It's very hard to bring this subject back home, because in a lot of homes, sex is not talked about, and it's not a topic that you can just sit over there and talk with your husband, right? Or wife. I would love for you guys to share just a little tip that you might share with your patients on taking this home.
I actually encourage, when I was working in the office, I would encourage my clients to bring their spouse with them or partner with them so that they could actually see and participate in giving therapy and hearing everything that I am saying, as long as the client is open to that. If they are not open to that, or if the spouse is not open to it, then yes, they would have to have that conversation at home, and then they would report back to me, what was said. But I think just in the beginning, a lot of times the spouses may not necessarily connect, like they're thinking about everything, right? You're thinking about the diagnosis and living, and what does that entail. And so we don't think about the life afterwards, what that is going to entail. And I think that's where they're able to hear my heart and hear what could be, or at that point it's usually what is going on at the time. There is no sexual desire, or maybe one partner has it and the other one doesn't, or maybe they have had other issues in the bedroom before any of this even happened. And so now this just kind of escalates everything else. Um, yeah, I really feel like having the conversation on the front end will prepare them for what is going to come afterwards. And most, I can't say most, but some spouses are very supportive. Like, they are there, they're in the waiting room, they're doing everything with the client. And then you have others who are very much removed, don't want to have anything to do with it. So I think trying to figure out communication, giving people resources to read outside of the home, or outside of the clinic, is going to be something that also is helpful in that relationship. You don't know how many relationships have been restored just from them coming to pelvic therapy, because no one's ever talked about it, and they didn't know it could be fixed. And they come to me and they're like, I know this is my last resort. My doctor said it's probably not going to help. That's what I hear. And then, within 9 visits, 8 visits, they're able to have intercourse pain free. And they're like, what in the world just happened? Why didn't anybody tell me about this a long time ago? So I've seen it on both ends. So I would just encourage the conversation early on.
Yeah, I would say Katrina's noting that partners coming in together is extraordinarily powerful, and just normalizing this. I think she and I don't want to speak for you, but we both see this, right? So many people come in and they think it's their fault, or that something's wrong with them, or they understand that it's not their fault, but the partner thinks that something's wrong with the partner because their partner all of a sudden doesn't want intimacy. And so, just normalizing that, yes, sex absolutely can be painful. Women absolutely can have decreased desire after intimacy, and giving patients that knowledge and power to really understand that. And if that means 2 people coming into an office, which can be extraordinarily powerful, then absolutely.
May I add something else to that? I also have seen where women are in pain and their partners see that they're in pain when they attempt to have intercourse. And what will happen as a result is the partner then starts to develop erectile dysfunction. And it happens because they don't want their partner to be in pain. So it's kind of a communication that needs to happen between the two of them, so that one understands, hey, if I get this issue fixed, then it's probably going to help your erectile dysfunction. And sometimes the men are just kind of like, well, nothing can help this, or, they don't want to talk about it. They don't want to discuss it because it's a pride thing, right? But once the female, or I should say, the one who has the issues with vaginal pain, once they get that resolved, a lot of times it corrects the erectile dysfunction. I've seen that too. And I'm like, wow, the body is amazing. There's another book. I can't think of the author right now, but it's The Body Keeps Score. I don't know if you've heard of that.
Yeah.
Yes. And so it just, again, speaks to how we hold so much within. And whatever you've been through, it can also be seen in the muscles within your body. So within your pelvic floor, within your diaphragm, right? It affects all of those different things. So there is definitely a mental health, psychological aspect of it, but there's also a physical aspect as well. So I don't want us to negate that, but that's what I wanted to share.
Thank you both for sharing your experiences and passion about the work that you do. We have the chat exploding with questions, and so I think it's a good time to move into Q&A. I'll just get started in reading like 2 questions that I saw in the chat, and then I'll give everyone the opportunity to either write more questions on the chat, or you can also unmute and talk about it. So I think, Katrina, this one is for you. In reference to prostate cancer, is there a window on when they would benefit from pelvic floor therapy when they have urinary incontinence after a prostatectomy?
Yes. So to be honest, I feel like all prostatectomy clients or those who are getting ready to have the surgery should have a visit before they even go in for the surgery. And we actually had a program at Baptist Hospital and also at Princeton Medical Center where we saw patients prior to them having the prostatectomy so that they would be aware of what they should be doing. So yes, it is never too early to learn about it. If you know they have a diagnosis, bring them in even before they have the prostatectomy. And then if you've already had it, they can start doing therapy 6 weeks later. Does that
Thank you.
answer? Hope that answers their question.
Yeah, so I was just typing as you were writing just to make sure that they have it here. And then another question from the chat: are there evidence-based brief assessments available to help gather needs of patients and guide to resources? I suppose this question is in particular about sexual health. Rachel, have you used anything like this in your practice?
Female Sexual Function Index is the most common one that we use for research purposes. It's 26 questions, and it's addressing various domains of issues with intimacy, so low libido, painful sex, decreased arousal, inability to orgasm. And I think if you get below like a 15 or something like that, it's considered sexual dysfunction. It might be 21, but that one can be helpful. It's just more. I recommend that for more thorough research. But if you're in an office, it can also be useful if you're trying to just hone in and capture, right? Because in my work, I have 90 minutes now to spend with the patient and get all of that information. Whereas if you're, trying to capture quickly, you could use something like that, score it, and then use it as a referral source to then say, oh, this person needs to go elsewhere. This is what the issue is.
I would also add another one is the vulvar pain questionnaire, the VQ. You can use that one as well as the pelvic floor distress inventory. That's another one, PFDI 20. That's a form, and then the VQ.
Thank you. And I'm writing these notes. I'll share this over email to everyone after the session, just to make sure you have all the resources that we shared. We have here one question for you, Katrina. Would it be beneficial to have gynecological cancer patients have a pre-treatment appointment with our pelvic floor therapists?
Absolutely. Yep. Even if it's just one conversation. Yes.
Thank you. Then happy to open the floor for any questions. You can unmute yourself if you want, or just write them here on the chat. And thank you for all of the notes you're having. Rachel and Katrina, I don't know if you have time to read the chats. You're getting a lot of love from the participants.
We have love for you guys too.
We do. I'm looking in the chat now.
Yeah. So opportunity to voice your questions here. Just gonna give a 10, 15 seconds of silence to see if anyone unmutes.
Ask away.
And maybe it's not a question, it can be a comment.
Mhm.
Just feel free to be part of the discussion with us.
I can't see any questions on my end. I just see the last two comments that were made because I think you may have answered some of them. Oh, there it is.
I just want to say,
Katrina, I'm sorry. This question is for Katrina. Katrina, I'm a pelvic floor therapist also in an oncology practice. And you mentioned one of the things that is affected is libido. And I'm just questioning how we can help with that from the pelvic therapist standpoint. Would it just be more vagal nerve and anxiety treatment and referral out, or do you know of any other interventions? Thank you.
Yes, those are the main ones. Doing a lot of breathing, vagal nerve reset, um, having them talk to their, communicate with their partner, what is going on, what they're thinking, even with body image, understanding that things may change, understanding they're beautiful the way that they are. Life is not going to always be this way. Like just really talking to them, positive affirmations. Those are some of the main things. And then I would begin to talk to them if they have a lot of pain issues, maybe give resources as to where they may be able to get dilators from early on, even vaginal moisturizers. Slippery stuff is a big one that we use. You may have heard of that. Uber Lube, um, Desert Harvest has some different products that is very helpful as well. So at least having resources on the lubricants, vaginal moisturizers, um, coconut oil, suppositories, those types of things before they have the actual surgery. And then, the physicians can tell them, when they can actually use these tools, right? So they're not going to use those right away. They have to wait for a specific amount of time. But having the conversation on the front end, I think would be helpful.
Thank you.
Thank you. And then I saw here another question about insurance. What has been your experience in terms of insurance covering your services?
So I don't take insurance in my practice. However, if I give a super bill, you can submit that and you can be reimbursed directly for those who have commercial insurances. But if you have Medicaid or Medicare, they will not cover those services. And then I also will refer people to other therapists who take insurance. So most hospitals, they're going to take insurance. There are some outpatient clinics that will take insurance. I just have had my experience with insurance companies for 20 plus years. And a lot of times they dictate your care, regardless of whether or not a person needs therapy, they will cut it off. And so I just got tired of dealing with that aspect of it. So in my own company, I don't, but I will give you the tools to be able to submit so that you can be reimbursed.
the other thing about insurance is that it depends, but the reimbursement rates also are not that great. So I am now also, I don't take insurance in my practice and I will give super bills, but my patients in my previous practice, I'm not sure that my rates now are that much more. I mean, it was a lot of money for some of these people to come in. I would say it was like $150 for an initial for some of them. And the pelvic floor PT too was more expensive for some of those patients than their private cash pay, which is really upsetting. So that's not to say that's the case across the board, but I think it's just important to note that. I'm going to put some ICD-10 codes in the chat if it's helpful for any of you, and you can always share those with patients and tell them that they can well, I'm going to tell you what the diagnosis codes that I would use are. I don't know what the actual ICD-10, just Google ICD-10 for low libido, for example. But have them call their insurance companies and say, like, if I went to a provider that was covered by insurance and this is what they charged, what would you cover? What would the rate be? And that can maybe help some patients parse out, am I going to go within an insurance system or am I going to go cash?
Thank you for sharing that. We still have a couple of minutes. I'm just gonna give everyone last opportunity to ask questions or to share any comments. Tasha is asking if in private pay settings are HSA and FSA typically accepted. I would say yes, if the provider has that opportunity. For example, at the After Cancer, we accept HSA and FSA payments. I see that oftentimes in more like private clinics. They accept those HSA and FSA, but don't accept private insurance. Perfect. Thank you so much, everyone, for engaging in the chat, asking questions, sharing your passion about sexual health. It really is a topic that is not talked enough, either by oncologists, patients. We really see that there's a huge need in bringing some of these resources to the practices and to you all. I will follow up by email with all the books and resources and assessments and the codes that were shared in the call, so you can take this and use this within your practice. And then just to close off, if you have any questions about how we can support you, you're welcome to reach back to me. You will receive my email. It's mariana@theaftercancer.com. We have a lot of education resources about sexual health within our survivorship program. Rachel and Katrina are part of it. We have videos of PT, pelvic floor therapy. We have chats with an expert with Rachel covering some of these questions that we covered here, but making it really patient-friendly and patient-focused. So always happy to share more about what we do. Thank you, everyone. Have a good rest of your Wednesday. And it was absolutely lovely to be here with you today.